knock this out in like 20 minutes, okay? And then y'all see me again after your psych test. We'll do a comprehensive review and y'all will be good for next week, okay? Okay, so this is our last one with me, lecture 5. You will see Colonel Johnston next week. We're going to be going over a little bit of reliability and a little bit over actual tubes themselves, okay? Okay, so TLOs are always the same. In ELOs, we're going to talk about reliability, accuracy, sensitivity, specificity, and predictive value, prevalence of positive and negative values, and then we're going to analyze how, no, we're not going to talk about that. All right, so your reference, chapter 3, 8, and 18. All right, our clinical introduction scenario. A 22-year-old asymptomatic patient undergoes routine screening for a low prevalence infection using a rapid antibody test with 90% sensitivity and 95% specificity. The result is positive. However, due to the low prevalence in this population, confirmatory testing reveals a false positive. The provider explains that even highly sensitive tests can yield misleading results in low prevalence settings, highlighting the importance of understanding prevalence impact on predictive values such as PPV and NPV. So the reason why this lecture is relatively important to you all is because when you do your clinical inquiries, this is what your professors want to see. They want you to know that you understand positive versus negative predictive values. You got to ensure that you're providing the right information as far as statistics goes. Okay, so this is jumping into the equipment. I wish you all had this in lecture 1, so I will probably do this next semester. But this is just showing what we use when we, or what you all will be using when you collect blood, okay? All right, so we're going to start off with evacuation blood tubes, all right? Each tube is going to be color-coded. Each color will indicate whether there's an anticoagulant or not, and will inform you what type of anticoagulant is in each tube and what type of tests you can do for each. So they all have this vacuum function. It ensures that the blood volume is collected properly and you have the right ratio of additive to anticoagulant versus blood. When proper mixing, please do not vigorously shake that. Please don't do that. Just make sure you're inverting it very carefully. It is very important that you use the correct order of draw so that you prevent any cross-contamination. All right, and here's some more containers. So you see the ones off to your left there. Those are those blood culture tubes that we send to micro. And then we will talk about each one of these tubes. These are just some pediatrics. Make sure if you're drawing from peds and you have to draw multiple tubes on the babies, make sure that you're always doing red, then green, and then purple. Okay, and this is just another FYI. We'll go into a little bit more in this next slide. Okay, so as you can see on this yellow top here, in the middle there, you have that gel. So on the bottom, when you first get that tube, it'll start with gel. When you collect that blood, it'll go into the tube. You want it to sit for a little bit. And when you send it to us, we'll put it in the centrifuge. And what ends up happening is those formed elements, so there's red blood cells, white blood cells will fall to the bottom. That gel will be right on top of those formed elements, and that will separate that plasma or serum from the formed elements of blood. And so that depending on which, if you have one that has anticoagulant in it versus non-anticoagulant, will determine which type of test you will run on that tube. So here's just an example. You collect first. You want to invert about 5 times. This is the one off to your left that doesn't have anticoagulant in it. You want to let it sit for about 30 minutes. Allow those formed elements to clot. And then we as laboratorians will place it into the centrifuge for about 10 minutes. And then that's where that plasma and the blood will be separated. So the plasma is really what we will use in like chemistries and serologies, testing like that. So the one off to your right side has anticoagulant in it. The only difference is you're not waiting for that tube to clot. You don't need any clotting. That's why anticoagulant's in there. And then we will run the testing off of that plasma, the yellow. Okay. All right. So this is an important slide. Okay. So you all will see this. So purple top or lavender top contains that EDTA. This is the tube that we will use in all our hematology studies, okay? So CBCs, differentials, we also use this in blood banking as well, okay? Light blue top contains sodium citrate, all right? And that's the anticoagulant that prevents that binding, prevents that clotting. We use our light blue tops in all of our coagulation studies. So PTs, PTTs, APTT, fibrinogen, that's the type of tubes that we use, okay? Red top, so we have two different types. We have a plain red top that doesn't have anticoagulant in it, and then we have what's called a tiger or marble top, and that has that clotting factor that's in that gel, okay? So that gel, all it does is kind of help increase the clotting, and it activates it a little longer. And of course, that gel is used to separate that blood from the serum, okay? So we use red tops that doesn't have the gel separator or tiger marble top tubes in chemistry a lot. And sometimes we use a little bit of blood banking. But for testing purposes, red top, tiger, marble top, think chemistry testing, okay? Then we have our green top tube, which contains the lithium heparin. That's used in a lot of chemistry panels as well. So cardiac panels, renal panels, and liver panels, okay? Okay, so do you remember EDTA is the purple tops are used in what type of testing? Hematology, right? What's the other one? Light blue top. Green top.
Cardiac.
Yeah. Yeah. And red top. Yeah. Okay, y'all got it. All right, gray top tubes has a potassium oxalate in it. That's the anticoagulant. We use this in a lot of glucose tolerant testing and blood alcohol. So you may be future commanders. You may have to do a command-directed blood alcohol test. This is the tube that we use to collect that. Then we have our dark royal blue top, and we use this a lot in toxicology testing, and that is Colonel Johnson will provide that lecture. Okay? So make sure you know those tubes. There's that picture again of that dude kicking some random, I don't know what that is. But anyway, so rejection of unacceptable specimens. We don't like to reject specimens, but we do if you do not send it to us correctly, okay? So make sure administratively that it's labeled correctly, the requisition meets what's on the label, and that the request is completed in the system, okay? We also have specimen quality reasons for rejection. So hemolysis, y'all remember what hemolysis is? Rupture of red blood cells. Then we have lipemia, y'all remember that? Yeah, increase lipids, fat in the blood, and then icterus. What's that? Yeah, bilirubin, yeah. Now granted, some of this may be the patient, some of this may be the way it's collected, but if you have any concerns, please call us. We will do our best to work with you to still get that specimen ran, okay? So if we have short volumes, like quantity not sufficient, that could be a reason to reject. Clotting, when it's not supposed to be clotting, could be a reason. If your patient was supposed to fast and they didn't, we could reject that. Improper transport, things like that, okay? Right, so big three, like we just talked about, jaundice, lipemic, and hemolysis. Those are big three unacceptable specimen conditions. We already know what hemolysis is, so I'm not going to go into that. And we don't need that. Okay, so quality and testing reliability. So there's about 6 or 7 questions off of this, just this subject alone, okay? And I will let you know which ones to look for. So quality systems, what is it to us in the lab and you as clinical professionals? So it's our formal system ensuring test accuracy across all test phases. So pre-analytic, analytic, and post-analytic. That just means we're making sure before we're collecting, while we're collecting, and after collecting, we're constantly checking on ourselves. So key components, we're looking at the integrity of that specimen. We're making sure that we are always assessing ourselves. We do calibrations and controls, so QCs and quality assurance on ourselves, our processes, and our instrumentation. Personnel competency, that's it. If anybody's been in the hospital, you know about those 6-sided competency assessment folders. That's pretty much what that's saying. Equipment maintenance and quality assessment. Okay. So Remember, every time I give you a test, and I always give you those normal ranges, this is pretty much just saying how a normal range is derived. So you want to take about 120 plus healthy individuals, usually between 120 and 150 people, with results spanning in a 95% confidence. And then we will, from there, do our low and highs based off of a +2 or -2 standard deviation. So 2.5% high is our high value, 2.5% low will be our low, and that's how we make a reference range pretty much, okay? So false positives or false negatives, these may misidentify conditions of presence or absence of a condition. And we're going to talk about reliability and variability. Okay, reliability is precision that varies by test. Variability is sample handling timing and lab variations that affect results. All right, so true positive, that's pretty much saying that this test correctly identifies the disease state or result, right? So a pregnant woman takes a pregnancy test, it's positive. So that is a true positive. A true negative, this correctly rules out a disease. So if a person who's not pregnant takes a pregnancy test, it's negative, true negative, okay? False positive incorrectly suggests disease. So if you have a woman who's not pregnant and comes up with a positive pregnancy test, false positive, okay? And then lastly, false negative, this misses the disease presence. So if there's a pregnant woman, she takes a pregnancy test, it's negative, that will be considered a false negative. All right. Yeah, for disease. Okay. 3 types of errors. Random errors, systematic errors, and human errors. So random errors can be unpredictable stuff, environmental fluctuations, things have Murphy's Law, right? Systematic errors, this could be the flaws in the measuring device, so instrumentation errors or theoretical errors. And then lastly, human errors, making mistakes, not crossing your T's, not dotting your I's, things like that, transcription errors. All right. Then we talked about this. False positive incorrectly suggests disease, while false negatives miss the actual diagnosis. And this slide, I want you to know this slide, okay? So, 4 key indicators commonly used to assess or measure tests: reliability and validity. So reliability is how well that test performs day to day. So under reliability, we have precision and we have accuracy. Precision is that consistency of results that repeated over repeated measurements, while accuracy is the closest to true value, okay? And then we have validity, which is sensitivity and specificity. So sensitivity, think the ability to detect that presence of disease, all right, while specificity rules out the disease. So sensitivity in, specificity out. And there's another one that breaks it down a little bit more. So you will see this again, and I will use one of those mnemonics on the test, okay? So sensitivity detects the disease presence, while specificity detects the absence of the disease. And these are just some examples. They're nice to look at. Not going to be tested. Maybe a little later, though. Juniors and seniors, you may need this, but not here. All right. The effects of prevalence, sensitivity and specificity are not affected by prevalence. In sensitivity, it depends only on the test's ability to detect disease. And specificity depends on the test's ability to detect disease absence. All right, but the positive predictive value and negative predictive value are affected by prevalence. Okay, and you'll see this again: positive predictive value and negative predictive value. Okay, positive predictive value, when the prevalence is high, there are more true positives and fewer false positives. So increasing the PPV and decreasing NPV. And then the opposite for negative predictive value, when prevalence is low, there are more true negatives and fewer false negatives. Okay, so here it does, it breaks it down again. Go ahead and start this, because I have like 2 questions for you on the difference between a positive predictive value and a negative predictive value. Okay, so positive predictive value, probability that the person truly has disease when testing positive. So the example here, a COVID-19 test with a high positive predictive value means that most positives truly have COVID. So you think your patient has COVID, you test them for COVID, they have COVID. positive predictive value. Negative predictive value, the probability that a person truly does not have the disease when testing negative. So a flu test with a high negative predictive value means most negatives truly don't have the flu, okay? Oh, we are done. Shame, I think that's our breath. That was like 14 minutes. That's my PR, y'all. Okay, any questions? None? Okay, so I will be back right after your psych exam to do a comprehensive review. Okay, any questions, nothing? All right. See, and Captain Blaine still didn't show up, so good. That's it.
So Kevin,